Hi, my name is Claire. I'm the founder of Student RDH and Smarter DA. Get ready for your unofficial dental hygiene podcast.
These are the tales of two hygienists, one East Coast RDH and one West Coast hygienist. Listen as they tackle the profession of dental hygiene with humor and enthusiasm. Now, please join Michelle Strange and Andrew Johnston as they tell you a tale of two hygienists.
Welcome back, everybody. Episode 95 of Tale of Two Hygienist. This is Andrew.
This is Michelle.
Hello, Michelle.
Hello, Andrew.
How's it going?
I'm trying to figure out how I can balance coffee and my microphone.
And your laptop.
And my laptop.
Without falling over and breaking things. So I know you're in meetings all morning, but I'm going to just lead the episode with this one little message we got from our buddy Tim Ives. Did you see that message?
I did not, because I was seeing patients actually this morning.
Oh, yeah.
And then followed up with
Sorry, my bad.
Actual meetings.
As you listeners may recall, we just did an interview. Well, I mean, the interview was a while ago, but we just did the episode with Tim and Trisha O'Hare and O'Hare University, and we posted it. And whatever Michelle just did to her camera made it all weird and fuzzy, so I don't really see her very well anymore. But when we posted that interview, a lot of the comments that we got were, "Is it accredited? Is it accredited? Is it accredited?" I don't know if you saw any of those. I tried to answer those without getting you involved too much, Michelle.
I missed all of that.
Yeah. Well. Yeah. Okay. Well, we don't need to really talk about that, but like part of it is, Michelle and I believe very strongly in who. I don't want to say who cares if it is accredited, but like I kind of want to say like who cares? Like just get a good education, no matter where you need to get it at. And this is a really good education. The program is phenomenal, and so if you have to pay a little bit of extra money, get a little transfer something next to your name. Who cares? You're smarter and you're a better hygienist for it. But we don't need to get in that whole tangent. I want to read you the message that Tim sent to us. He said, "Exciting news. OHU, which is O'Hare University, is very proud to announce that the University of Minnesota recognizes our BS degree in oral health promotion."
Way to go, Minnesota.
OHU grads who want to pursue a master's degree in dental hygiene following either an education track or a management track can apply to the University of Minnesota dental. Let me try that one more time. This is like your story time. So I can't read this.
It's not so easy, is it?
It's the words and like the letters that are all like, next to each other.
The sentences.
Yeah. The sentences is. All right. Okay. Can apply to the University of Minnesota Department of Dental Hygiene. The requirement that your bachelor's degree be from a regionally accredited university will be waived if all other application requirements are met. The MSDH degree has two tracks, education or management. The education track is fully online, and the management track will be converted from a residency program to an online program in 2018.
Way to be, Minnesota.
So congratulations to Tim and Trisha.
Yes.
And also thank you, Minnesota, for pioneering this and being cool about it.
What I love about them is that they've had all these people all saying, it's not accredited, but they believed in what they had. They stuck to it. And they are ahead of we always know, like, they are way ahead of the game.
Right.
And now people are following.
Do you remember in the interview what they said? I'm not going to get this right because I'm really terrible about quoting people and things and places and whatever. But they're like, you know how successful you are by how many arrows you have in your back.
Yeah.
And I'm like, yeah, well, this is just kind of goes to show that, yeah, they really are ahead of the curve. And congrats. That's just such big news. It's pretty amazing. News. So, yeah, that's pretty much my morning.
Nice. That's really awesome.
All right. So, listeners, we have 26 reviews now on iTunes, which I think is phenomenal for a dental hygiene podcast. I tried to look at a couple other ones, and I didn't see any other ratings that had, or any other podcasts that had 26 for dental hygiene. So I think that is pretty awesome. But if you
It's
do
hard to
listen
be a
more
niche
than,
of a niche.
it is really hard. But I was gonna say, if you do listen to ours and you listen to theirs also, and you've only rated ours, not theirs, go and support everyone else, because it really does
Good
make a
point.
big difference
Good
to
point.
get all of our stuff out there and let them know that dental hygiene is important. Okay, so apologies again, listeners. This is a little bit late. We are in middle of October, and this is from the middle of September. We have 2 new ones since I think that we've read since last time. One good and one not as good. So let me read the good one first. And then the second one's kind of longer, but whatever. We'll get into that one. Okay. The first one, 5 stars, fantastic podcast by Innisfree, INISFRE 1. And this is from the 22nd. It said, Andrew and Michelle have absolutely made me a better hygienist. I love all the knowledge and wonderful topics, speakers, and general information. If you haven't been listening, you're missing out. Please keep up the good work, and I hope to see you guys in person. So worth your time. Thanks again.
Oh, we hope we get to see you too.
Yeah,
Thanks.
and come tell us that it was you, because
Yes.
I can't decipher who you are exactly by your iTunes handle. Anyway, okay. So the next one is it's entitled Bittersweet, and I think that's like a perfect title for the particular multiple sentences paragraph that they left by CCT84, and this is from a dentist. FYI, this is not the most flattering one that we've gotten. Anyways.
Well, you said we had one good, one bad.
I know. I hate getting negative reviews, but it's good.
It's actually more me getting a negative review.
It's not. Okay, we'll talk about it in a minute. Okay, I recently found A Tale of Two Hygienists listed in Dental Economics podcast episode, and as a lower podcast in dentistry, was intrigued to check it out. So, by the way, thank you, Dental Economics, for putting us in with all the dental podcasts. That was really cool. As a dentist, I was looking forward to hearing dental topics from the dental hygienist perspective and getting, quote, in the mind of what their day-to-day trials and tribulations are like. I have a great working relationship with my 2 hygienists, both of who are relatively new grads, and I'm always looking for ways to coordinate efforts to I think it's supposed to be to best treat our patients. Please don't beat your patients. It's the reading thing. I'm not so good at the reading thing. Okay. I also have an amazing, hardworking dental assistant who is in the process of applying to hygiene school. So I thought the podcast would be a great resource for me to help guide her as well. I was dismayed to hear Michelle's negative attitude towards dentists as a whole, and it turned me off the podcast. In the How to Pass the Dental Hygiene Board Exam episode, you heard her discuss that a dentist is one of the board examiners, and she comments how, if competent, this dentist must be one exception to all the others. I was also disappointed to hear her call out dentists for not being good leaders or managers, while at the same time expressing she hates the business side of hygiene, and I think probably she meant would like to, quote, take a nap during talking of it. Dr. Salerno's episode is the one that she's referencing to, she said, because all she wants to do is patient care. As a dentist and hygienist, you have to know the business side of things. We live in an insurance-centric world, unfortunately, and it's imperative to know how this affects our patients and the care they receive and what they ultimately pay out of pocket for. PPOs have a huge impact on dental practices. It's irresponsible for both dentists and hygienists to turn a blind eye to all things aside from patient care. I very much like the idea of this podcast, but as a dentist, I don't feel welcome as a listener.
I kind of, sort of, almost a little feel bad because I don't want dentists to think that I hate them. But you also have to keep in mind we're all a little bit of a product of our experiences.
Exactly.
And mine have not been good in the past with dentists at all. I mean, I have literally been told that I would be a better hygienist and assistant if I had no ovaries, 3 arms, and bigger boobs. That's my experience with dentists. Bullied, definitely had people who needed treatment get nickel and dimed versus the people who didn't need the treatment but lived in an affluent area get whatever they want for free. Like these are my experiences. So I definitely don't have positive ones. However, the flip side is I'm meeting more and more dentists that are challenging that view for me. So I hope throughout the podcast you do hear that how excited we get when we do meet the good ones, at least me. I still hold true that I think that dentists should not be actually, it would be more the exception to the rule if it was someone that can detect calculus properly on our boards.
I think, yeah, I mean, so it kind of goes both ways. And I see, gosh, there's so many things I want to say about this. You know, how many dentists are out there that say, I hate doing oral surgery. I hate doing endo. I hate doing this as a general practitioner or as a general dentist. Like, I don't feel like there's very much wrong with you saying that. I don't like business. The business side of dentistry it makes me hurt inside because we can't deliver the patient care that we know that we need to give because of money and business and insurance and all that kind of stuff. So I understand where you're coming from on that, but I also think that it's kind of, does she not think that there are any dentists that hate a particular side of what they do also? I mean, I just, it's okay for you to feel that way. Like, there's nothing wrong with that.
Oh yeah, I still hold true. I hate business. But I also think that I accept it. I don't like it, but I know it. I understand it. I would choose never to talk about it if I could.
Right.
But I do. But I
like it though. I love the business side of it, and I think it's important.
Which is, it's what makes us all tick, right? There's something that we love about it. But so I do feel bad because I don't hate all dentists, but my experiences have not been on the positive side of it, unfortunately. And so they have been a product. Like, even though I still come across the good ones, there are going to be moments in that, like, that are deep-seated, like, visceral reactions to some things that are said that that's probably never going to change, mostly because, again, I spent 1 year starting in dentistry crying almost on a weekly basis because my hand was, like, smacked away like I was a 2-year-old because I wasn't assisting properly. Like, these are the things that I always kind of correlate to a dentist. Being bullied, bad management, bad leadership. But that's awesome that she has this great, like, relationship with her staff and her team.
It's rare to be that good.
So good for you. That's great. Sorry you don't like my disdain for some of dentistry. But sorry.
Yeah. Sorry. I think to wrap this part up, I appreciate the crap out of the time that she spent to write that long of a message, though. Honestly, I would say that too. You and I would be doing the same things if we felt the same way, and there's no other way really for her to express those types of thoughts and have other people who might be feeling the same way be able to share those thoughts as well. So while obviously it's not the most flattering on our part, thank you very much, Doctor, anyway, for taking the time to let us know what's going on and your thoughts on that.
I agree. So we have Kris Potts on the podcast today.
Yes, we do. Texas.
Yeah. Hopefully we hear some y'alls in there. Some good Texas y'alls.
Some good Texas y'alls.
And Kris talks to us a little bit about, she has a great program on prehabilitation. And so we're going to hear a little bit about that, and you'll understand what prehabilitation means after this interview with Kris Potts.
Hey, Michelle.
Yeah?
It's time for the interview.
Oh, but I had something else to say.
We need to let the experts talk now.
Fine.
This is the last one for today.
Oh,
we are so excited for that.
Thank you.
Not that we don't enjoy. We love our job.
Maybe for last.
Not
we
at
did.
all.
Yeah, the best for last. You've heard that.
Yes, the best.
Didn't
for
that
last
originate in Texas? I
day.
feel like it might have. I like one of your guys' sayings. But
you're not the last, like, because we are exhausted, but your information is going to be really needed. So we are at RDH under one roof.
Correct.
Still.
Yes.
Interview
number 13.
Oh, God, is it?
It is.
Jesus. No wonder.
It was like 13 hours worth of talking just for the podcast.
In addition to the booth.
In 2.5 days. Well, yeah,
And the floor.
I don't
and
have
the
to do
exhibit
that.
hall. And oh
Yeah.
my God.
Poor Michelle.
So we're here and we have Kris Potts.
A long overdue guest. I am
Yes.
really sorry about that, which is mostly my fault. We
Really?
talked about it in midwinter. Yeah, I think so.
Did I miss that she was supposed to be somewhere and we missed it?
No, not necessarily. I just
okay.
haven't prioritized like I'm supposed to.
Well, Andrew also has a problem with doing things like through the internet, and he wants to be in person all the time, which doesn't always work for people's schedule to always be in the same place at the same time. I'm hoping he's moving past that after this whole ADHA incident.
I'm working on it, but Kris, welcome to the podcast finally.
Thank you. I appreciate you having me. It's really an honor. I've listened to the podcasts many times, and I am envious of all the other people that you interviewed with, and you make it sound like so much fun and everything. So,
well, we hope we don't let you down with all that
really.
that big thing, but
we hope it is all that you hear on the other end of it.
But just to make life better, though, Michelle did just get her wine.
I did.
Brought to her by producer Mike. And
life is good now. I was tired. I am rejuvenated. Let me take this first sip. Give me 1 minute.
Yeah, I'm going to take your first sip. Also, he brought me a Red Bull. So, brought to you in part by Red Bull. Red Bull gives you wings.
I hate you. So, Kris, you're a hygienist.
I am.
For like 2 years. You're such a baby hygienist, right?
Oh, yeah. I was introduced at a presentation I gave the other day. She's been practicing for 100 years. And I said, no, no, 99 and a half. So I added it up not too long ago for something, and I got my license 38 years ago.
Wow.
Fantastic.
So it seems like forever.
But did it fly by? Ish.
I love it.
Ish. Ish.
No, but can we talk a little bit about that? Why didn't it fly by? What happened?
What have you been doing?
Life.
Yeah.
You know, because aging parents, raising kids, things like that. But that was the beauty of it back then. More so than now, I think, was the flexibility that it offered. You could work 1-2 days a week. You could work 5 days a week. When my daughter was small, I stayed at home, but was able to go back in. It's like riding a bike in a lot of ways, and so it was very flexible. And for me, that was great.
And so, you practice how many years clinically total?
I have not. I hung up my scalers about 6 years ago.
About 6 years ago.
About 6 years ago.
Okay, and what have you been kind of focusing on? Where's your passion now?
Right now, my passion is with oral care for the oncology patient. I've been educating on different aspects of helping hygienists and consumers make informed oral health choices, educating them on the products that are out there, the techniques, because it has changed so much over the years. But the main thing I think now is the focus on the oncology. I have other topics that I speak on, but the oncology is what's kind of near and dear to my heart.
Why did it become near and dear to your heart?
Probably going to make me cry.
Oh, gosh. Then it'll make me cry. So let's not cry.
But,
and Andrew will cry. Well, I'll cry.
I don't think that there's anybody that their lives have not been touched in some way by cancer.
Yeah.
I am a breast cancer survivor. My mother passed from pancreatic cancer. And really the impetus and the focus for the presentation that I'm about to give, I lost my best friend of 35 years.
That's rough.
And so I really think the paths that we're put on in life, we can take it down this road or we can take it down that road. And things that occur to us, they could be bad, they could be devastating, but it's what we do with it. And so I really think that I have been directed down this path to use what I have learned as a caregiver, as a survivor, to help others.
Now, did you personally go through chemo or radiation?
I was fortunate that I did not. I had the best of all possible outcomes every step of the way. I know that many are not that fortunate, but especially it's kicking in right now. The xerostomia is overwhelming.
Yes.
And as a speaker, as an educator, and someone that talks a lot, the xerostomia, it can be life-altering with that. And that's one source. But my best friend went through agonizing mucositis with her treatment. And as a hygienist, I felt like I could be doing more.
Right.
But I didn't know. And back then, our options were very limited. And we have got many, many, many more options today than we had then.
Okay. And what are those options that have changed?
Products, back then she had 2 options. And now there are so many other options. And one of the things that I try to drive home to people is that you have to ask questions. You have to target their treatment, because what works for one is not going to work for another. What are you trying to accomplish? What is your desirable outcome with this? That's going to make a difference in which product you select.
Yes, okay.
And there are many, many different choices, but you have to do some detective work with the patient, and you have to find the product that meets their needs.
So when we are looking at oncology patients, that's going to hopefully be a very collaborative experience.
It should be more than it is.
All of medicine, right? All of our dental profession
definitely.
should be more collaborative than it is. But so you and I have talked about this before, and we kind of were chit-chatting about how if a patient had a hemorrhoid that was infected, that might be taken care of before an infection in the mouth, because people don't really still understand the fact that chronic disease in the mouth and chronic inflammation and infection matters.
It's all connected.
Yeah, it's crazy.
And if they've got an infection going on orally, that can affect the outcome of their oncology treatment.
And so what's the protocol now? It's like, because I remember once upon a time, having patients come in for extractions prior to chemo or radiation or whatever they were going through. I mean, is that a very similar protocol that's happening, or are we kind of changing it up? Like, could we get them healthier first before we start chemo, or is it just kind of dealing with the aftermath?
That varies a lot with the individual. If we're talking about head and neck cancers, they are very, very fast moving, and treatment needs to begin as soon as possible. And there may not be time, especially if they don't have a dental home, they are not regular with their dental treatment. And so in that instance, yes, you've got to kind of put out fires.
Okay.
But in other cases, there is more time. And ideally, which is what I talk about, is preventive prehabilitation. And that would occur ideally between diagnosis and the beginning of treatment.
And what does that look like?
Again, it's going to vary with the individual, how frequently they have been seen by a dentist. Their attitude, they have obstacles to overcome. They may think that's the least of my worries, I can't afford it. So there are things that we have to overcome with that, and that's where bringing the oncology team into it is important, because they need to stress to them that yes, you do have to get this taken care of, because it's going to affect the outcome of your treatment.
Right. And because essentially, I mean, you can't, if your body's already suffering from all that chronic inflammation orally, then it's like there's just too many fires happening, and you can't put them all out or fight the big one as efficiently, I would imagine.
True. And I think, too, that when you're in the midst of treatment, most people feel like, dirt.
Yes, yeah.
And the last thing they want to deal with on top of that is a toothache or pain in their mouth.
Right.
So if we can identify potential sources of trauma, if we can identify potential problems pre-treatment and get those taken care of, then hopefully that's not going to be one of their concerns during their oncology treatment.
And is this kind of a treatment as far as prehabilitation happening in the dental office or in the oncology, or is this like at home, or what does that look like?
Again, it varies. I think most of the oncologists, I refer to them as the Sheldon Coopers of the medical world.
Love it.
They are excellent at what they do. They are brilliant.
But emotional intelligence.
And taking it, being able to translate it to an average person's everyday life is very difficult for them.
Yeah.
So they don't know, and a lot of them don't even think to look in the mouth. They are so focused on, we need to cut it out, we need to radiate it, we need to nuke it with the chemo, we need to do all this other treatment, and they don't think about it. So we need to bring them into the conversation.
Right.
Another obstacle with the medical community is that they, dentists aren't real doctors. Right? We've all heard that before too. So I mean,
we just have a high school education as hygienists. So.
Oh well, yes, that too. But if we can get them to realize, we are the experts for the oral cavity, you're the expert for the oncology, and we can help each other because our goal is that individual that's just been diagnosed.
I agree. Actually, I just had this conversation on Facebook with Daniel Lopez, and
shout out again to Daniel.
Daniel, he's always
he makes
on
every
it.
episode.
He really does. It's usually because he and I are always in trouble on Facebook somehow.
That's true.
But we were talking about like the guidelines after heart attack, the patients after a heart attack and or bypass surgery, and everyone was just screaming 6 months, 6 months, 6 months. We're like, that's actually not the guidelines, though. You read that one, Mike?
I think I followed that post.
Yeah. Did you see when we just started answering in gifts where we just slammed our head into the wall? And I think I was pissed off the other day on the podcast about it too. But my point that I was trying to get across, because they're like, well, we'll just yield to the cardiologist, and I'm like, but the cardiologist probably didn't look in the mouth. So would they feel differently about the guidelines if they knew that there was some severe infection and we need to clean that up? Like, would they heal better? Would you have a different? Because again, we are the experts. We're looking in the mouth. And, I called somebody the other day about pre-medication after hip replacement. And, the guidelines say some need it, some don't. Most don't anymore. Yield to the surgeon. And the receptionist was just like, for life. And I was like, actually, I'm just curious about, because this goes against the guidelines. Could you have somebody actually call me and explain to me if there's a reason that she had a particular problem?
And I'm sure she loved you for
I know
that
she
comment.
did. I'm sure. And I'm calling from a volunteer outreach program, and she's like, who the hell is this? And I was like, you can talk to anybody when you call. I probably won't be here, but
just want to make that point.
Yeah, but it's the point is that I don't want to challenge the oncologist in their expertise, but can I give them more information about something that they might not be seeing?
Can we have a conversation about this?
Right. Yes.
I think that's the important thing, because we discussed this in an earlier class today, that ultimately the oncologist is the highest authority with that. And but the patient is really the ultimate authority, because they can tell the oncologist to go take a hike. They can change.
They can tell us to take a hike. All those things. Yeah.
Exactly. But giving them the information so that they can make an informed decision, then that is their choice. It's just like that tooth needs a crown. Well, I don't think so. I just want a filling. That's their choice. We can't make them have a crown, but we give them all the information. They make an informed choice. We agree, maybe we don't agree, but let's have a conversation about it. And that's what the collaboration is all about.
Absolutely. So is there so you got prehabilitation, anything particular they need to be being aware of during treatment?
I think so. They need to know what to expect,
Okay.
because I think in an oncology certification class that I was in, there was actually a nurse in there that said, we don't always tell patients all of the side effects of their treatment, because if they knew, they wouldn't do it.
Holy crap. What?
That's what I thought.
Oh my God.
And whatever happened to informed consent?
Yeah.
I would be
Livid.
so angry if you didn't tell me that this was a possibility.
Yeah.
If I didn't do this, that this is what could happen. But that's my choice to make. But I need to have the information.
Wouldn't you just put it that as far as the risk at which you will get these? Like, okay, you're at a higher risk at this complication or side effect. Look, this is a complication side effect, but you're in the low risk category. You told me, you informed me, but you've kind of helped me not freak out over seeing the list. You kind of told me where I might go, where I might not.
Have you looked at the papers that come with the most recent prescription that you had filled?
Isn't it like 10 pages long or something?
It's enough to scare you to death.
Yeah.
All the what ifs and ands and stuff. And most of the time that stuff's not going to happen. But if you educate them, and I think that's where we can come in, that if this happens,
we have an option for you.
Then try this. When this happens, you need to call us. When this happens, you need to call your oncologist. And if they know that, chances are it won't ever happen. But if they know how to react, they don't just freak out.
Right. Helping them manage that, because I'm sure that there's some moments, especially with excuse me, I was almost got a hiccup.
And
the wine has got me.
And there's a lot of the new products that used preventively can prevent a lot of the oral complications from occurring.
For instance?
There are some, there's Mugard, and the Salivamax even has been shown, at least anecdotally, I don't know if they've got the research behind it or not, but used regularly, started prior to the oncology treatment, they have really mitigated the side effects of that. They are less likely to get mucositis. It's not going to be as severe. It's not going to be as frequent. They don't have as much trouble with their nutrition because of the swallowing effects and things. So there are things, but it's going to vary with individuals.
Okay.
But there are certain things that they can do, and if they're doing it regularly, it's like the old flossing thing. Cleaning interdentally is essential. If they've never flossed, now's probably not the time to start.
And that's that's something that we wouldn't normally think. We're like, no, get it healthy. So, but because they're going to have other issues, do we want to? Is that kind of the thought process? Like, do we really want to stir things up?
You could stir things up. I think a lot of oncologists are afraid of that, and they tell patients, don't brush, don't floss. And I'm just going, are you crazy?
And this is where we go back to, like, would you tell a patient with an infected hemorrhoid not to take care of that?
Don't poop.
Don't do any of the things that you should do to clean yourself so that you don't continue infection. But in the mouth, it's a different world.
And they don't do that. And there are a lot of them that still have that philosophy of don't brush, don't floss, don't disturb the bacteria.
It's very
in there.
antiquated.
So the alternative is to let it grow and multiply and inflame the tissue
and create this the Taj Mahal of bacterial colonies.
Exactly.
Yeah.
So there are other alternatives that they can do. They don't have to floss. Like I said, it may not be the time to start, but there are other things that they can do. Cleaning interdentally is important.
Right. It might not have been ever the tool for them anyway.
Correct.
So stop bashing them in the head. Sorry. So things that they can do, prehabilitation during the moment, and then Are there certain things that we as hygienists need to be like aware of after the fact?
I think so. There are a lot of emotional aspects that an oncology patient experiences that, unless you have experienced it or someone very close to you have, you may not be able to relate. Turning their head, neck fatigue, their cervical vertebrae can be compromised if they've had head and neck radiation.
Okay.
We automatically jump to that they're being a PETA. And they're not. They have a legitimate reason.
Right.
They may need more of the suction. They may have to use the saliva ejector more frequently. And we think that they're being a PETA, but they're not. They have a real need for it. So laying them back in the chair. Again, we see it all the time. The doc comes in, lays them all the way back, and we're asking,
You're like,
how do
actually,
you
doctor,
sleep?
could you put me on my head? Because I find that's more helpful.
Well, I think part of this though is taking good health history, because if you don't get that information ahead of time, then that's exactly what you're going to think, is they are so needy, and then you're going to post on Facebook about how needy your patient just was.
And it's an interview process. It's more than handing them a clipboard and saying, are there been any changes? Sign here, we'll put it in the chart. You have to ask questions.
Yes.
Because a lot of health histories don't ask about prior use. They may ask about current. Do you smoke?
Yeah.
No, but I used to. So that means that they are at a higher risk. Do you drink? No, but I'm a recovering alcoholic. That puts them at a higher risk. But you have to be able to ask those questions, and they're not ones necessarily that they're going to disclose.
We talked about that with Lisa this morning about medications and schizophrenia medications. They're not always going to disclose that they might be suffering from that mental illness, but you need to know well, that medication kind of coincides with this, and then just not ask shaming questions, but kind of and figure it out though, because there's going to be
just
other
clarifying
complications
questions
for that, right? Exactly.
I like what you said though. Is there are, you mentioned specifically head and neck radiation specifically. And there's lots of different types of procedures that could happen, but if you ask, have you had radiation, and that's all you ask, well, where have you had that?
Right.
It's very important to figure out where.
My husband had a lesion on his shoulder back when he was a child that was radiated for treatment. So, yes, he's had radiation, but it didn't affect his head and neck. It has had no long-term side effects other than the scar that he has from it. But it, makes a big difference. Like you said, you have to get a little bit more specific. And why did they have head and neck radiation? Because it could be as simple as a thyroid abnormality that they had treated.
Right.
And we don't necessarily think of that as being on the same level as oral cancer, but it still involves the head and neck, and it still is going to affect their oral cavity.
Don't they know we're podcasting?
Is it tape? Okay, let's just wait for a second because that's driving me crazy. So
where did we stop? I'm sorry.
You want to rewind the tape? I'm sorry, I don't remember.
Do you remember the last thing you said?
No.
Oh, man.
We might have to just start a new topic.
Okay, so now that we've been interrupted by all hotel functions, so in your presentations, what are do you hear common questions or common concerns from hygienists? Repeated things? They're I didn't know this, or
not so much that, I think, as that the intimidation that maybe they feel from the oncologist, that, and even their DDS employer, a lot of times they don't feel that they have the same concern, the same passion that they do. So I talk to them about coaching up, because we're learning a lot of stuff here this weekend.
Yeah.
And I know the tendency is to go back and just fire hose the office with all the new products and all the new information that we
just talked
have.
about that yesterday.
Yeah.
And that's a real tendency that we have. But
Fire hosing the office is a really great metaphor for
I
that.
like that term.
but we can coach up, especially since, we just barely have the high school diploma and all that.
I'm pretty sure I trained in a garage.
Oh, did you? Okay.
Yeah.
All right then.
In high
another
school.
country?
Yes.
Yes, okay.
Yes,
Yeah.
exactly.
Right.
I'm actually a dentist in another country.
That happens. But your front desk has to be on board with this as well. The dental assistants have to be on board with it as well. The whole office has to function with the same mindset and have the same passion. One thing about getting the patients in a timely manner, because you have a patient that's been a patient of the practice for 20 years, and they just received a diagnosis. They call the office and they said, hey, I've just been diagnosed with whatever liver cancer, and I've been told I need to get a dental exam and dental clearance before they'll start treatment.
Will that be an actual thing that they come to us with? Like, people are saying you need to do this?
Hopefully, they should.
Okay.
That's part of the prehabilitation, because they should be getting healthy. Okay, if at all possible.
Okay.
Before they start their treatment. But then the front desk says, well, our first opening is not until January. They need to move people.
Yeah, make it work.
They
make it
need
happen.
to get them in today.
Yeah,
if
I
they
agree.
can.
Okay.
Or tomorrow.
Okay.
Okay. Oh, yeah, but I have the kids' soccer game after work. I can't stay late. Well, what if that was your mother?
Yeah.
There.
Yeah.
Wouldn't you want somebody to take that extra time and that compassion?
Right.
For them. And so, again, the front desk has to be on board, has to be aware of what is going on and how emergent that exam is.
That's a good point. I had a question, and it literally left my mind. Damn it.
I saw it. It went that way.
It did, didn't it? It turned the corner. Let me see if I can come back to me. It did it this morning. It popped back up. Stop it.
Thank you. Thank you.
Kris has done such a great podcast that they are applauding for her.
Yes.
Cheering for her. Oh, wait for it. Okay, maybe we'll move on.
Let me turn my microphone on because I had to turn it off. While I was writing. Anyways, so the experiences that you've had, though, you're an expert in a lot of different things. What are some other things that people could reach out to you for information on, or as an expert on, and maybe helping mentor them?
Recommendations to make for the products, I think the right questions to ask, what to look for in a product, because there are a lot of products out there that make a lot of claims that some may be contraindicated for some patients. Some are, what works for you is not going to work for you. So we have to really investigate and ask the right questions. And the answers to those questions are going to determine what products we recommend. Then you also have to have, with any product, it has to be accepted by the patient. If it's not palatable to them, if they're not using it, it's not doing anybody any good. It also has to be effective, because there are a lot of things that our patients are doing, things with oils and different things like that are not really effective, that we are not going to achieve the desired outcomes with that. And then it also has to be atraumatic, because we don't want it to do harm. And a lot of those things that our patients are using and are trying can actually do damage to the teeth and or the tissue. So there are a lot of things that we have to take into consideration. And what I hope to do is at least plant the seeds, put the thoughts out there, stop and think about it rather than just a crossword. This is what we've always recommended. This is what we have on hand. This is what our office purchases. This is what has always been recommended. Stop and think and inquire and investigate with your patient.
Hallelujah. Preaching.
It's too bad this is in
I'm from the South. Yeah, I can
I
preach
know,
it.
you preach it. Praise Jesus.
How often do you speak? Do you speak quite regularly?
It comes in waves.
Yeah.
This fall is
You're going to be in Georgia.
I will.
I'm trying
I
to see
will.
if I can clear my calendar to come to Duluth, right?
Yes.
I was just there for GDHA's thing, so.
This
quick
is
drive
the
from
season.
Charleston.
It's going to get busy.
Yeah.
Going to be in Kansas, a couple of places in Texas, Georgia, Florida. A few places
Come
like
to
that.
South Carolina.
Well, ask me.
I'll get some people. I'm gonna ask because we got Angie finally.
Right.
I'm excited.
I haven't been to South Carolina.
See,
so-
not our state meeting is in Myrtle Beach, which is not Charleston. Sorry, Myrtle Beach, but it's not. But it's
I haven't
fine.
been
It's
to
on the
either
beach.
one, so-
It's on the beach, and then you can come to Charleston, and I'll show you Charleston.
All right.
She's a great tour guide. Everyone that goes over there, she
Yeah.
gives them
The best tour guide is a local.
Absolutely.
Yeah.
Absolutely. So, and then how can people contact you if they want to ask questions or follow up with anything or get your speaking schedule?
I have a website, krispottsrdh.com, and I spell Chris with a K.
K-R-I-S.
Yes. And I have a lot of information on there. There's a couple of different landing pages. There's one for oncology care, oral care, discuss just some facts on mucositis and different things. There's a somewhat comprehensive list of products there, but if they want more, I've got a more intense list that they can contact me. If
nice.
The speaking dates are up there. If they are interested in booking something and stuff, there's a way to contact me through the website as well.
Perfect.
And I am out there on social media, so they can Google that and find me that way.
Find you there. Thank you. It wasn't
you,
so
Chris.
scary, was it?
Sorry,
a
it's so
little
chaotic around this place.
I know.
Though.
Well,
That's the part I feel bad
that's just
about.
this meeting, though. It's just chaotic.
It hasn't been this bad, though. This
It's
has
usually
been
not this
like
loud,
it's pretty
but-
rough.
Yeah.
But thank you for coming on.
you're
Well, thank you for having me.
Thanks for being a friend of the podcast.
Yes.
Honestly, you've been really supportive of us, and we appreciate that.
I try. I
Yeah.
try. I enjoy it. Right now, it's too hot to go on my morning walks.
Oh, yeah.
And I can't wear my headset in the pool, so I haven't. I'm kind of falling behind a
That's
little
okay. You
bit.
can like binge
Hey,
at
yeah,
some
but
point.
binge when it comes cooler. That'd
Yeah.
be great.
Yeah, I
That's
will
usually
do.
what I do with most of my podcasts.
I will do. But you all make me laugh.
Good. Oh, good.
Oh, thank you.
I hope you're laughing at us because I don't actually like when people laugh at me. No, I'm kidding.
But thank you
No,
very much
thank
for having
you.
me.
Of
Love
course, of course.
It's about that time. Grab your blanket and a glass of wine. It's story time with Michelle.
Okay. So what was so wonderful is that we decided to do Chris's interview, which was on oral cancer and prehabilitation and the oral cavity and things like that. A few days after, I met with a head and neck oncology surgeon at the medical university, just talking about oral care. And I was working with them because Tepe has like these extra soft post-surgical brushes and getting some of their patients with, pretty extreme mucositis and whatever. So I was kind of meeting with them. I also wanted to understand it a little bit more, the rehab side of it, especially after these just major head and neck surgeries, like remove mandible, half of tongue kind of surgeries. Like
Right.
I can't even imagine. So from that doctor, I got a great, it's called oral pharyngeal cancer update. Excuse me, my allergies are bothering me, so I'm trying not to sniffle while I do this. It's by DMD, Angela Chi, Dr. Terry Day, who's an MD, and Dr. Brad Neville, who is a DDS as well. And it's oral cavity and oral pharyngeal squamous cell carcinoma, an update. So I am just going to go through, it was in a cancer journal for clinicians. I'm trying to look for the date. It's this year, so I'm pretty almost positive. But so I'm going to just kind of read through the intro and then also just kind of, go back to the treatment and discussion section since, I'm not trying to put you to sleep with
Thank
this.
you.
You're welcome.
Wait, were you talking to me or the listeners?
Actually, more you.
Oh, okay.
Just kidding.
Well, I'm sure the listeners also appreciate that.
All right. So the introduction. In the United States, squamous cell carcinoma, also SCC, accounts for approximately 90% of oral and oropharyngeal malignancies. Oral cavity SCC, also known as OC-SCC, Lord, I'll never get those acronyms proper, is the most common malignancy of the head and neck, excluding non-melanoma skin cancer. There has been a dramatic rise in the incidence of oropharyngeal SCC. This article updates a prior review from 2002 and presents the latest evidence regarding the incidence, mortality, etiology, risk factors, clinico-pathological presentation, clinical assessment, imaging, staging, and management of oral cavity squamous cell carcinoma. Anatomically, the oral cavity and oropharynx are separate regions that border each other but do not overlap. The anatomic subsites of the oral cavity include the labial mucosa, buccal mucosa, floor of the mouth, alveolar ridge, and gingiva, anterior 2/3 of the tongue, anterior to the circumvallate papilla, hard palate, and retromolar trigon. The oropharynx consists of the soft palate, base or posterior 1/3 of tongue, palatine tonsils, palatal glossal folds, valleculae. God, man, talk about a review of anatomy, and posterior pharyngeal wall. Distinct anatomic borders separate the two sites from above the junction of the hard and soft palate and from below the circumvallate papilla. Reviewing the literature and surveillance data on oral and oropharyngeal cancers is difficult because these tumors often are reported in aggregate with other pharyngeal or head and neck malignancies. And anatomic subsite definitions are at times unclear and may not allow for distinction between the oral cavity or the oropharynx. For example, in the surveillance epidemiology and end results database, the tongue is considered a subsite of the oral cavity and pharynx. However, the tongue includes the base of the tongue, lingual tonsils, which are part of the oropharynx, as well as the anterior 2/3 of the tongue, which is part of the oral cavity. Good God, this is why I don't like to do research from the data side of it. That's serious. Also, the SEER database, or SEER, lists the oropharynx and tonsils as distinct subsites, although the tonsils are a part of the oropharynx. In the Globocan database, the oral cavity included the base of the tongue, which is part of the oropharynx, and the palate, which may include both hard and soft palate. Also, the nasopharynx and the other pharynx are considered distinct subsites, with the latter referring not only to the oropharynx and tonsils, but also the hypopharynx, the piriform sinus, and other ill-defined sites of the lip, oral cavity, and pharynx. Good Lord, who knew? There was so much. So let me kind of just skip through all of that part. Okay, so in a pool analysis of case control studies by the International Head and Neck Cancer Epidemiology Consortium, adults aged 45 years and younger exhibited higher proportion of oral tongue cancers compared with adults older than 45 years. 16% in women, 11% in men, and versus 10.3% in women and 5.9% in men, respectively. Also in that study, the associations of smoking and drinking with oral cavity cancer were weaker in younger adults compared with older adults, even smokers. In addition, in a study of 25 young adults diagnosed with oral tongue squamous cell carcinoma at a single institution from 1989 through 2007, Harris et al. Reported that 60% were female and 52% were never smokers, never drinkers. So it's not an old man's disease or, anymore. Like that's kind of what we always thought, like these cancer, pipe smokers, cigar smokers, heavy whiskey drinkers. It's not the case, 60% being women from this one study. The major risk factors, of course, were tobacco consumption. I'm just going to kind of quickly go through that. HPV I'm going to just, because this is very upcoming, right? Like HPV, we're learning more and more about.
It seems like all of the
yeah.
major conferences have some sort of someone speaking about it.
Right. It's on the rise for sure. So over the past decades, accumulating evidence from epidemiological and clinopathologic and molecular studies have established HPV as a major etiologic factor and a subset of the HNSCC. The majority of HPV-related SCC arises in the oropharynx, particularly the palatine and lingual tonsils. In contrast, only a small proportion of oral cavity SCC appears to be caused by HPV. Specifically, the high-risk genotype HPV 16 accounts for the vast majority, approximately 90 to 95% of HPV positive OPSCCs, whereas that's oropharynx SCCs, if you didn't catch that. Whereas greater variability in HPV types are seen in oral cancer or oral cavity SCC. That's crazy. For OPSCC, prevalence has been reported to be highest, about 60% in North America, immediately approximately 36 to 45% in Asia, Oceanasia, and Europe. It's interesting. Sorry, I'm kind of like I'm taking a break to make sure I understand this.
All right.
In particular, many large-scale studies have assess the presence of high-risk HPV DNA without concurrently evaluating biomarkers of HPV carcinogens, thereby failing to distinguish between passenger versus carcinogenic HPV infection. Nevertheless, with attempts to correct for some of these limitations, a recent systematic review and meta-analysis of studies reported worldwide from 1990 to 2004 estimated that the HPV attributable
I wasn't going to say anything. I was just going to let it just go. Attributable.
HPV attributable fraction is approximately 40% for oropharyngeal SCC and 7 to 16% for oral cavity SCC. That's just nuts. All right, it's kind of skipping around. Ooh, they got some nasty pictures in this article. Some really... the one thing I asked him, because, I did kind of a little research on my oral cancer, had neck surgery before I met with him. And I was like, when you see these patients, do you ever just feel like, where do I start?
Yeah.
Because some of them are so aggressive and take up, literally your entire jaw. Like, as a surgeon, do you go in there and be like, let me just start here and pluck away? Or is there some kind of method to the madness? Of course there's a method to the madness, but when you look at it from us that is not used to seeing this, I was just like, God almighty, scary. All right, so the treatment section. The standard of care should follow the National Comprehensive Cancer Network guidelines whenever possible as appropriate for a given patient. Multidisciplinary care may include specialists in surgery, radiology, radiation oncology, medical oncology, dental oncology, nursing, and speech pathology. Current National Comprehensive Cancer Network treatment guidelines remain stage-dependent, although modifications based on HPV tumor status may be recommended in the future. Most early and late stage OCSCCs are treated surgically with clear 1 centimeter to 2 centimeter margins. In addition, neck dissection typically is performed when lymph node disease is evident or when there is an elevated risk for occult regional metastasis. I don't know what occult means. OCCULT?
I'm on it. I'll look. I thought it was something bad. I thought the occult was the bad thing. Supernatural, mystical, or magical beliefs, practices, or phenomena.
OCCULT? Occult?
OCCULT.
Wow.
It's a supernatural, mystical, or magical beliefs, practices, or phenomena.
Okay, so it's evident when there is an elevated risk of occult regional metastasis. Interesting.
Hold on, there's got to be something else.
There's got to be a medical side to that, right?
Oh, there it is. Medicine. Oh my gosh. Of a disease or process not accompanied by readily discernible signs or symptoms.
There we go. See, we don't know everything. I like that we can just work it out, though. Thank God for
I
Google, the
I
Google
feel like
machine.
we could easily like edit all this out if we wanted to.
Would you like to?
I don't know. We'll see how long it is, and then we'll make our decision.
Okay. Stage 3 or 4 OC-SCC typically requires combined treatment with surgery as a primary modality, and the need for adjuvant radiation or chemoradiation therapy often dictate by adverse findings. Although optimal treatment of the clinical lymph node negative NEC or OC-SCC remains controversial, requires further study. Management is based on assessing the risk for occult regional lymphatic spread.
Do you want to know what adjuvant means?
Yeah, sure.
A substance that enhances the body's immune response to an antigen.
Thank you, Google machine.
Or of therapy applied after initial treatment of cancer, especially to suppress secondary tumor formation.
That makes more sense. Now,
Saying.
this is the last little section, but I think that this is really interesting because I've seen actually multiple Facebook posts about the HPV vaccination. Have you?
No. Oh, I don't do Facebook very much anymore.
No.
It's too
Good for you.
I get angry about everyone being dumb and things.
Well, you were attacking it better than me, whereas I just get pissed and then say stuff. Let me finish this. Okay. The availability of vaccines targeting high-risk HPV types offers great promise in controlling the rise of OP-SCC in the future. HPV vaccination currently is approved by the U.S. Food and Drug Administration for the prevention of carcinoma of the uterine cervix and anogenital wart. In the clinical trial, including over 7,400 young Costa Rican women randomized to receive either the bivalent HPV-16 or HPV-18 vaccine or the hepatitis A vaccine as a control. His name was Herrero et al. Reported vaccine efficacy of 93% against oral HPV 16 and 18, approximately 4 years after vaccination. However, prevention of OP-SCC is not yet an approved indication for HPV vaccination, and further studies are ongoing. In addition, there is a need to address barriers in vaccination. With regard to HNSCC, the oral cavity and oral pharynx represents more than just different anatomic sites. The etiopathogenesis, diagnosis, treatment, and outcomes for tumors involving these sites have been diverging for over a decade. It is important for clinicians to be aware of these differences so that the appropriate patient education and multidisciplinary care can be provided to optimize outcomes. HPV vaccines may have the greatest potential to reduce the morbidity and mortality from OP-SCC, which has been increasing in incidence in the U.S. and other developing nations. So it's not like we ever see that side of it, but I've had a couple patients that I've had post cancer care. Like one had her literal rib as her new jawbone, and the other ended up passing away from additional cancers, but she had half her tongue missing. But it's crazy. I'm so happy most people are surviving, but this just goes to show we got to be on top of finding these things and point it out. Don't be scared. Say something. What's Debbie Z's thing? Say something. See something, say something because you care.
If you see something, say something because you care.
Thank you for doing the hand movement as well.
You're welcome.
Not everybody could see that, but
well, you could. I could. To you.
I did it. Okay, so that is story time with Michelle. Do you want to close us out, Andrew? Since you haven't done it in a few weeks.
Yep. Bye, everyone.
Wait. We always appreciate your reviews on iTunes. Don't forget to share the post. I'll never give this to you again. Don't forget to share the post on Facebook, because the more we're understanding about algorithms of Facebook, the more you share it, the more you like it, the more you comment on it, the more people see it, the more information, more of these, people like Kris Potts can get their message out there to the hygiene world, dental world, whatever it is. So we always appreciate that. You can always email us at ataleoftwohygienists@gmail.com or send us a message. And we always appreciate you interacting with us, guys. We really do. Andrew, you get all that?
I did. I hope you learned your lesson about letting me close things out.
All right, guys. We hope you have a great week.
All right. Bye, everyone.
Bye, y'all.